Okay, great. So I'm so excited to be giving this lecture. I really appreciate you guys coming to listen to me. I'm really glad that Chris Joyce is here so he can correct me when I get it wrong. So the basic idea behind the elbow, we're going to start with the anatomy and then move on to biomechanics. The basic idea behind the elbow is you can really conceptualize the distal humerus as two fingers holding a spool. There's these two columns, the lateral column and the medial column. And basically, one of their main purposes is to stabilize the trochlea in the middle. And if I can imbue you with one fact for this lecture, it's that the trochlea is the center of the elbow. And that we just, if you look in the book, it describes the elbow as like a trochleogyglimoid joint, I think. And like, I don't know what those words mean, but I think you can basically think of the elbow as a hinge. And the trochlea is the pin within that hinge, whereas the greater sigmoid notch is the cradle that rotates around that pin. And like, I think that's a much simpler understanding of the elbow and will be much more useful to you in your understanding of like when things go wrong, what do I do about it? So anyway, I've found this little image that I stole from Skeletal Trauma to be particularly helpful when thinking about the elbow and simplifying things when it gets complicated. So let's talk a little bit about the osseous anatomy. So, and maybe you can go through A through E for me here. What are each of these? What are each of these osseous features?
A is the trochlea, B is capitella, and then E is the condyle.
Mm-hmm. And then C and D?
C is the coronoid process, D is radial head.
And then on this image, what is this big swooping thing here?
The olecranon fossa.
So this is what's referred to as the greater sigmoid notch, and the olecranon fossa is in the back.
Okay.
This is coronoid fossa and radial fossa, and then there's also another cutout on this side of the ulna that D interacts with. What's that cutout called? So that's called the lesser sigmoid notch. So there's these two kind of semicircular notches on the proximal ulna, the greater sigmoid notch, which interacts with the trochlea, and the lesser sigmoid notch, which interacts with the radial head. And I think you know all those things, and I'm just like asking the question in a weird way. So again, we talked about earlier, the elbow, I think you can really conceptualize as a hinge, and I think this is the most useful way to think about it. And then we've been through a lot of these features already. One of the main reasons I wanted to bring out this image is really where it comes to here, which is that as I mentioned, you can think about it as a hinge, and there's these cradles that rotate around the pin in the middle, and those cradles have to have spaces to duck into. So this analogy is very useful to explain to patients in clinic when they have stiffness because of osteophytes that have formed either on the tip of the olecranon of the coronoid fossa or within, the tip of the olecranon of the coronoid or within the olecranon of the coronoid fossa. So those cutouts, the fossa allow flexion and extension. If you don't have the fossa, you will not be able to flex and extend. The reason why this is useful to understand is because then you can understand exactly why the patient is lacking flexion or extension. So if you have a patient who comes in and they have good flexion but not good extension, you know that either they have a stiffness problem in the front, like a capsular tightness problem in the front, or they have something stuck in the back. So for instance, most of our baseball players that come in with elbow stiffness, almost all of them are lacking full extension, not full flexion. The issue is usually posterior osteophytes. So you guys with me there? If the patient can't flex all the way, then the problem is anterior osteophytes or posterior capsular stiffness. So that's kind of what these pictures show, and hopefully that's relatively straightforward to understand, but I think is really a useful thing to keep in mind as you approach the patient with elbow stiffness. Because you will definitely see stiffness as a major feature of the pathology we see within the elbow. That can come from osteophytes, it can come from heterotopic ossification, which the elbow is also prone to. We do not exactly understand why, but the capsule within the elbow is particularly, the tissues in the elbow, I guess I should say, are particularly prone to heterotopic ossification. This is clearly because of some sort of biochemical circulating thing. So for instance, if you have an elbow trauma, there's a small risk for heterotopic ossification. If you have an elbow trauma and a head injury, that risk is like 10 times higher. If you have just an isolated head injury and no elbow trauma, there's still a risk for heterotopic ossification in your elbow. So clearly there is some circulating factor that causes heterotopic ossification. We don't understand. But usually it will present where the patient says, I can't move my elbow, and you see this x-ray. So again, as I mentioned, the name of the game in the elbow is motion. And this is the same as the shoulder. I think you guys already know this, but really this is embarrassing for me to admit because the hand surgeons would all probably think that they're better than us. But really the only purpose of the shoulder and the elbow is to position the hand in space. Like these two joints that I've devoted my entire life to are really doing is positioning this thing wherever you need it to be in space. Now, the problem is, of course, that if you don't have good motion with those joints, then your hand is much less useful to you. This is also useful to you because if you see a patient in clinic with a non-functional hand, then their shoulder and their elbow doesn't really matter that much. So all the time we see patients here who've had some sort of, neurologic lesion in their brachial plexus. They have a hand that doesn't work. They come in with a shoulder complaint, and I'm like, it doesn't matter. Like whatever's going on with your shoulder doesn't matter because you can't position your hand. So if the complaint is not pain, complaint is like, oh, my shoulder doesn't move well, it doesn't matter. So the elbow in this regard is more important than the shoulder. And the reason why is because if you have a stiff elbow, you greatly reduce the sphere of motion through which you can place your hand. And the normal range of motion of the elbow is usually considered to be 145 of flexion to 0 of extension. By convention, 0 of extension is straight. This is not 180. This is 0. And then all of the bend from there takes on the number. So if you say the patient has a 30-degree flexion contracture, what you mean is the patient is 30 degrees shy of full extension. And then 145 is full flexion. So if you say the patient is lacking 30 degrees of flexion, you mean the patient can only flex to 115 degrees. I said that right, 110 degrees. So this is the normal sphere. Generally, it's considered to be that what we use in our day-to-day life is 30 degrees to 130 degrees. That comes out of a very old paper from the Mayo Clinic. Bob Tashton has actually done a subsequent study that shows that you probably use more than that in your day-to-day life. But I will say that it's been relatively consistent for me in clinic that patients will present for evaluation when they get to that 30 to 130 phase. And we'll often say it's been getting stiffer for years, but it's starting to get to the point where I can't do the things I need to do. What are your thoughts on that, Chris? Like, when do you think the patient usually comes in to say, I'm unhappy with it now?
I mean, if it's like stiffness related that they come in, it's flexion less than.
Okay.
What I found, and it's,
yeah.
Because they can't do some basic or something like that.
Yeah, generally people will come in and they'll say like, I can no longer tie my tie, or I can no longer shave, or I can't brush my hair anymore. And then generally I will say that loss of extension is more well tolerated than loss of flexion, for the reason being that if you can't get your arm straight, you can generally just move closer to whatever you're reaching for, with certain exceptions. There are certain patient populations for whom loss of extension is prized. Climbers are probably the one we see the most frequently, because if you can't get your arm straight, you generally can't reach a hold that's farther away. So I've generally found that climbers will get all their extension back. They'll fight for it, they'll get it back. Okay, so that's the range of motion. So as we talked about before, if you develop osteophytes, then you can lose that range of motion. You have to take those out, or the patient can stretch until the bone face, and then they get the range of motion back. We talked about this already. You have to remove those to get flexibility back. Generally we'll do that arthroscopically. And this is where I think it becomes important to understand that when you look at the anatomy of the elbow, when we talk about the coronoid, you think about often the book labels the coronoid as though it is it's a process to which the brachialis attaches, and that somehow it's like like it can be avulsed off with the brachialis. And that's totally false. The brachialis is not attached on the coronoid. The brachialis attaches distal to the coronoid on the ulna. The coronoid is an entirely cartilage-covered intra-articular structure, and you can see that right here on the arthroscopy. This is the tip of the coronoid. It doesn't have anything attached to it. So there's no such thing as a coronoid avulsion fracture. If you see a patient with a coronoid fracture, that's generally from some sort of instability event. The same is true of the tip of the olecranon. So the triceps attachment is on the back of the olecranon. It's not on the tip of the olecranon. And there's actually somewhere between 5 and 7 millimeters of the tip of the olecranon that is intra-articular, that it does not have anything attached to it. Maybe it'll have some capsule attachment, but it doesn't have any triceps attached to it. So this shows the outlines here of the triceps insertion on the olecranon. The same is true of the radial head. So it's about 270 degrees of the radial head that is covered in articular cartilage. And there is somewhere around a 90-degree area of the radial head that is essentially non-articular. And the reason for that is because that's the area that's not interacting with the lesser sigmoid notch on the ulna as you come through full pronation and supination of the forearm. It's worth noting that normal pronation and supination, normal supination is 80 degrees, normal pronation is 70 degrees. It is not normal to be able to get to 90-90. There's no one who can pronate 90 degrees. You can't get your radius to rotate that far on the ulna because the ulna is in the way. So there's always going to be this safe zone. Generally, the safe zone, and this is important for you to know because it's on the quiz you have to take once a year, is considered to be between the radial styloid, like if there's this the radial styloid, and these two things is what we're supposed to define the safe zone. Does that sound right?
Listers.
Listers, yeah. That's the name of that tubercle, yeah. That information is on the quiz, and it's really only useful if you're trying to put a plate on the proximal radius, and I've put 0 plates on the proximal radius, so I'm not really sure how useful that information is, but it's on the quiz every year. And then this image shows something that I think it's really important to understand, which I think you guys already know, which is that when you form protonate and supinate in your forum, the radius rotates around the ulna. The ulna doesn't rotate. So when you look at the proximal radius, we talked about the fact that there's 270 degrees of articular cartilage. And then the other major feature of the proximal radius is the tuberosity. The tuberosity is not the attachment site for the distal biceps. The distal biceps attaches on the far side of the tuberosity. The tuberosity acts as what's called a cam. And basically the way that a cam works is, and there's several of them in your body actually, is that a cam is a place where if you have a rotating object, it widens the radius such that the line of pull is acting on a larger radius and therefore has greater mechanical advantage, as it's able to create a greater mechanical force angularly on that rotating object. So what's happening here is the tuberosity pushes the line of pull of the biceps farther away from the center of rotation for forearm and pronation on the radius, and therefore gives it greater mechanical advantage, because as you guys remember, that's what the radius, that force is by the radius squared. The same is true for the greater tuberosity in the humerus. That increases the rotational force of the infraspinatus on your humerus. Okay, so radial tuberosity is not that, you guys are clear with that? Everyone understands that? Okay. The next thing is the capsule of the joint. The capsule generally is the lining of the joint. It also contains thickenings. These thickenings are the ligaments. The ligaments are not distinct anatomic structures. They are thickenings within the capsule. This particular capsule has generally a bunch of different structures within it that we're going to go through. The first, and the one that's on top in the center, is called the anterior capsule. The anterior capsule is essentially a diaphanous, in normal people, is essentially a diaphanous structure that provides almost no stability to the elbow. You can remove the anterior capsule and it should not influence the structure of the elbow. Okay, that's different from the medial and the lateral collateral ligaments, which are generally important for the normal function of the elbow. We're going to go through each of those. So we're going to talk about the lateral collateral ligament first. This structure has a relatively complex anatomic structure and has a bunch of nomenclature issues that are confusing to people. So generally, this is the overall structure of it. All of it attaches on the humerus at what's called the isometric point. That isometric point is the center of the curvature of the capitellum. It then fans out. As it fans out, it attaches to another structure that goes from ulna to ulna around the radial head. It's called the annular ligament. This portion that goes from the humerus to the annular ligament is generally called the radial collateral ligament, which is very confusing because it doesn't attach to the radius. Nothing can attach to the radius because the radius has to rotate. Okay, so the radial collateral ligament goes from humerus to annular ligament. Annular ligament goes from ulna to ulna. And then there's a portion of that ligament that also goes from the humerus and streams down and attaches on what's called the supinator crest of the ulna, and that is called the lateral ulnar collateral ligament. It's called the ulnar collateral ligament because it attaches to the ulna, and the lateral one because it's on the lateral side. So this is very confusing. And the reason it's confusing is because it contains lateral and ulna in the same name. And obviously ulna is also a word we sometimes refer to the medial side of the elbow. So for instance, on the other side of the elbow, there's the ulnar collateral ligament. And what's confusing about that is it's sometimes also called the medial ulnar collateral ligament. And then you could even say that this one is, if this one is the lateral collateral, you could also refer to it as the more radial ulnar collateral ligament. And then the other one would just be the ulnar collateral ligament. But then you sound like a complete idiot if you just say the ulnar. Anyway, so what I'm trying to say is that this has this very confusing name, the lateral ulnar collateral ligament. Lateral is because it's on the lateral side. Ulnar is because it attaches to the ulna. Okay, great. Very confusing because the radial collateral ligament's on the same side, doesn't attach to the radius. So these are generally those bands. The one that's in the solid box is the lateral ulnar ligament. That's the one that's the most important. The one that's in the dotted box is the radial collateral ligament. The one that's in the dashed box is the annular ligament. Sometimes people will also describe a little accessory band down here that they'll describe as the accessory lateral collateral ligament, and I'm not really sure what that's doing or if it's biomechanically important, so I generally don't know that matters. The one that matters here is the one that's in black, and the one that's in solid black. And the reason why that's true is because that's the one that's isometric. So as you extend your elbow, you can understand how the radial collateral ligament is not necessarily isometric. There's only one band of this that's isometric. And then that one, when it tears, and it almost always tears on the humeral side, if you lose that band of tissue, then the elbow generally does not work anymore. So that, what's called the lateral collateral ligament tear, is a functionally important event. And we'll talk a little about why in a little bit when we talk about biomechanics. So again, that attaches on the center of the curvature of the capitellum, and then attaches on the supinator crest on the ulna. This shows after removal of all the ligaments. On the other side, the ulnar collateral ligament, or also called the medial collateral ligament. A lot of patients know this is like the Tommy John ligament, at least the baseball players do. This also has multiple bands. It's generally considered to have 3 bands. The one that's in solid black is the anterior band. The one that's in dots is the posterior band, and the one that's in dashes is the transverse band. Okay, so let's talk about these bands. The transverse band goes from ulna to ulna and is doing nothing, so that one doesn't matter. It's basically just the floor of the cubital tunnel. I'm not exactly sure why it's even described as a separate band. The one that's in dots is somewhat controversial, and there are people who do think that it matters. There is a biomechanical study that was done. There's been 2 biomechanical studies actually now that I'm aware of. One that was done at Mount Sinai, another one that Sean Driscoll did, that both suggest there is some elbow stability that comes from rupture of that structure. It may only be associated with certain rare coronoid fracture types. I've never repaired that structure, and I'm not really sure if I'm ever going to, so I'm not sure that it matters. I think generally the only reason why you need to know about it is because that structure can become thickened and can cause loss of flexion in patients with arthritis. Do you think that the posterior band matters or anything else? Am I missing anything there?
I don't think so. I think I know you're talking about Driscoll's posterior medial, where he caused the intermedial facet fracture.
Yeah.
I don't know. I generally think with these in an actual body, some of that stuff probably starts eventually. The anterior band matters, and that doesn't matter because they stiffen up so much anyways.
Right.
But I pretty routinely resected it.
I haven't seen any consequence to that. Have you seen any consequence to that?
Not that I've seen.
Okay.
Maybe it's seen you, but generally, I don't think so.
Did you guys see in your residencies any isolated posterior band repair or reconstruction? Okay.
Never.
Great. So I feel like I'm still in the right to say the structure doesn't matter. Okay, so then the one that's in black is the one that matters, and that's the anterior band. It's sometimes described as containing the anterior and the posterior bundles within the anterior band, and I'm not really even sure why you would describe that as separating bundles. Doesn't matter. What matters is that structure is the isometric one. That's the one that's the same length through flexion extension. I think this is the reason why the posterior band can't really matter that much, is because in extension it's not under stress. So that anterior band comes from the face of the epicondyle down to the sublime tubercle. And the face of the epicondyle, this is really important. This is like the most common mistake we see in ulnar collateral ligament reconstruction, is that it's from the face of the epicondyle. It's not from the tip of the epicondyle. So when you do an ulnar collateral ligament reconstruction repair, you don't want your tunnels and your anchors to be here on the tip. You want them to be up here on the face, and it has to be kind of under the flexor pronator. So that's a really critical thing that people do get wrong, that you want to make sure you don't miss. It's up on the face of the epicondyle, not down on the tip. And then, as I mentioned, it attaches down here on the sublime tubercle. And there's actually now multiple papers to show that the attachment actually comes. Do you see how the ulna has this kind of ridge here? That the attachment actually comes down this ridge. It's a little bit unclear how much that matters, but there are people who are talking about reconstructing down the ridge instead of just attaching here, and saying that basically, if you look at the attachment, there's almost a centimeter long kind of landing strip for it down the ulna. This is somewhat similar actually to the MCL in the knee, where it has that kind of long attachment on the tibia. Again, like right now, it's unclear whether that matters biomechanically, but that has been shown anatomically. This we talked about already, that there's only this portion in the middle that is isometric that you can see in this image, and the portions obviously posterior to that are only on tension and flexion. So we've talked a little bit about the ligaments. We've talked about the bones, the ligaments. Let's move on to the muscles and the nerves. So obviously the muscle in the back that you all know of is the triceps. The triceps is larger from a cross-sectional area than the biceps and the brachialis combined. So you definitely have more extension power than you do flexion power. I don't know if this is a holdover from us being quadrupeds and walking on our arms. If you look at quadruped anatomy generally, you will see there's a very enlarged olecranon process and there's a huge triceps. And there's generally less flexor power. Like all you have to do is, if you guys have a dog, you should look at your dog's front legs, and just look at the upper portion, and you'll see what I'm talking about. Okay, so that the triceps, as I mentioned, is large from a cross-sectional area, and it attaches on the olecranon fossa, which, because it is so far posterior to the center of rotation on the ulna, gives it, on the humerus, gives it just a huge mechanical advantage to extend the arm. This is the reason why triceps tears are generally quite debilitating. And while there are distal biceps that you will see where patients live with them, there are very few patients you will see with triceps tendon tears that are just living with it. And even I've had patients with like a 30% partial rupture of the triceps that'll be like, I can't live my life, it's too debilitating. The radial nerve travels through the triceps between the lateral and the medial heads, and is generally the bugaboo of accessing the humerus is the radial nerve, at least from the midpoint down, because the radial nerve wraps around the humerus. And on the anterior side, we talked already, there's the biceps and the brachialis. The biceps has this bifurcated attachment distally, where the main tendon comes down and attaches just on the other side of the tuberosity, but then it has this other vein called the lacertus fibrosus, here labeled as the bicipital aponeurosis. That structure is, I would say, of unclear clinical significance. Like if you rupture it, like we're not generally repairing it. But it's important for you to know, because it's the main number one way to find the median nerve in the brachial artery. If you are in the elbow and you can't figure out where you are, find the lacertus. Underneath it, you will find the median nerve in the brachial artery, and then you can use that to trace those structures to make sure you aren't going to injure them with whatever else you're trying to do. What do you think? Do you think the lacertus matters? Like, are you trying to do any lacertus repairs? No, I don't know what to think of it. I've seen, so Jeff Dugas told me that he's actually done multiple now of releases of it for patients with exertional compartment syndrome in the forearm. So I think it can, if you look at your own forearm when you flex, you can see a little notch there. So it seems to only cause problems. It doesn't seem to be good for any reason. The brachialis is deep to that. The brachialis is this huge muscle that comes from the whole anterior aspect of the humerus. And you can actually have a pretty much normal life with a complete brachialis rupture. There's a girl on our ski team that had this like awful injury to her elbow going like 60 miles an hour skiing, and she ruptured her entire brachialis in her elbow that you would never be able to tell. It's basically normal. So I'm not really sure the brachialis matters, but the biceps does seem to matter. And then above it, of course, is the coracobrachialis, and that should be covered in shoulder anatomy. Okay, on the medial side of the elbow, there's this thing called the flexor pronator group. And these are not, as you come proximal to the elbow, they're not distinguishable one from the other. What you mainly need to know is that the most medial is the pronator, and the most lateral or distal, so to speak, is the flexor carpi ulnaris. And they come into this one conjoined tendon. That tendon covers the ulnar collateral ligament. That tendon is a source of some issues with what's called golfer's elbow medial condylitis, which was already way less common than the other side, the lateral side, where we see lateral condylitis is by far the most common cause of elbow pain. So if you were to just take the patients in your clinic that are labeled as elbow pain and tell them they have lateral condylitis, you're going to be right like over half the time. So this labocondylitis is the source of a great deal of trouble in about 10% of the population. It comes from this structure called the extensor carpi radialis brevis. The extensor carpi radialis brevis has this diamond-shaped attachment on the humerus that is all just proximal to the LCL attachment. So you can find it by finding the mid-axis of the radius and coming just proximal to that. It's also deep generally to the EDC and ECRL tendons. And is usually right up against the capsule. And these pictures demonstrate that from this really beautiful anatomic structure study that Mark Cohen did. And then on the meat.
That was a really good picture, just showing why it's super common to have residual pain after a lateral treatment. Sometimes somebody's taking down the CL working, you can see how close that is.
Right.
When you're doing it, you're like this tiny incision, it's hard to tell.
So the general way to make sure you don't injure the LCL, I think, is you want to make sure that you are proximal to the mid-axis of the radius, and then you should be safe. But just in case when I do the surgery, I put in an anchor and I repair the stuff around it, and I'm like, okay, and then no, whatever, I repaired it, so it should be fine. So we talked already about the Lysertis fibrosis, the bicipital aponeurosis, and the way that it covers the median nerve and the brachial artery. And then obviously there's the FCU, and the FCU has humeral ulnar heads, and those form this arcade that covers the ulnar nerve, which can best be found just posterior to the median epicondyle, and that's shown in this image. The ulnar nerve is one of the most commonly compressed nerves in the body, second probably only the median nerve of the carpal tunnel. And there are multiple potential sites for compression. Osborne's ligament is the one that people describe the most frequently, but I think that's actually much less common than the deep fascia of the FCU, which is shown there as the deep flexor pronator aponeurosis. There's also this arcade proximally called the arcade of Struthers. Anyway, what I'm trying to say is you want to make sure if you're going to do an ulnar transposition that you get all these. The radial nerve can best be found at the elbow between the brachialis and the brachioradialis, and then it splits. It has this kind of trifurcation into the PIN and the superficial branch of the radial nerve, and then the PIN dives under the supinator. And this creates this thing called radial tunnel syndrome, and there is like no agreement as to whether the syndrome even exists. I'm like 100% convinced that it does exist. And they're generally patients with labocondylitis. They generally have pain more distally. And what I've been doing is if they have pain a little more distally with tenderness palpation over the radial tunnel, then I'll send them for a guided injection at the radial tunnel. If they get better, then they get referred to hand. What do you think? Do you think radial tunnel exists? You're a radial tunnel doubter, aren't you?
I don't know. I guess yes, and I just figured I'd never seen it until like maybe a month ago. I'm actually seeing the guy back today.
Maybe it only exists in Utah. It doesn't exist in Colorado.
Maybe. But I like your idea of referring to him. I don't really want to mess around.
The hand surgeons all hate it, so
Yeah.
So, but like you have them get a cortisone injection or a lidocaine, like block.
Cortisone injection, yeah, like a guided injection, yeah.
Yeah, I'm interested. You see, you've done that before, and you've had people, because it's just a pain symptom, right? It's not really this thing.
I say if it relieved your pain, then you can go talk to Dr. Garcia about it. And usually Dr. Garcia, they hate releasing it, but they'll do it. If I send them a patient with this, like, this patient had the injection, this patient has the problem, then there's like nothing else to say, you know?
Has it been shown, like, if you inject the ultrasound guided injection, it's not that far really from your virgin too, right? Okay.
Just
Okay.
Okay, so let's talk about the biomechanics. So the general way that people use their elbow, and I think this is a picture I took of my own arm during fellowship for a chapter I made, but generally people use their arms where they'll grab something with the arm away from their body with the arm in gentle flexion like this. And you think about what's happening in the arm here, and this one image, this one use of your arm can help you to understand actually a lot of the pathology we see within the upper extremity. So just starting distally, we'll see de Quervain's tenosynovitis. You could see how when you hold this, the wrist is in gentle flexion. The wrist is in gentle flexion because that, through the tenodesis effect, gives you more flexion power in your fingers. It gives you more grip strength to work with your arm in flexion, with your wrist in extension than in flexion or neutral. Because of that, people spend their entire lives when they're gripping things with their wrists in extension. Generally, that extension comes from your extensor carpi radialis brevis. So this is the reason why people get lateral condylitis and people hate lateral condylitis, is because people use their arms like this. This also creates a varus torque across your elbow. Now, you may be like, well, shouldn't that be balanced with a valgus torque? Well, nobody uses their elbow like this. Like, this is not a functional way to use your arm. And the general reason is because your body's in the way. So this is the reason why the LCL is more important for day-to-day life than the MCL, because your body's in the way. It's the same reason why MCL tears are more common than the LCL tears, because the other knee is in the way to prevent you from having that LCL injury. So this results in a varus torque across the elbow, and this is generally the reason why LCL tears are poorly tolerated. So while you can live a pretty much normal life without an MCL, you cannot live a normal life without an LCL. And most patients with a complete LCL tear, if it doesn't heal, will come back and tell you that they want something done about it, because they can't use their arm with their arm away from their body without the elbow trying to fall apart. You can also see that the arm is in gentle abduction in here, and this, I think, explains in part why rotator cuff tears tend to be so symptomatic, because the supraspinatus is generally the initiator of abduction. So I think if you just hold your arm in this one position, you can understand a lot of the pathology that we generally see within the upper extremity. Okay, this is totally different from the way people throw a baseball. So when you throw a baseball, your arm is up away from your body, and what happens during the throw is, and we have a lecture on this later in the year, but generally the stride downhill, down the mound, starts to create kinetic energy. That kinetic energy is transferred through rotation of the hips and the shoulders. And then once the shoulders are facing towards the batter, the arm is maximally externally rotated. So as you're coming down, then the arm comes all the way out this way. With the arm in maximum external rotation, there's this moment in the pitch that's called the late cocking early acceleration phase. And generally in this one moment, all of that kinetic energy that's been created by the stride downhill, the rotation of the strong muscles you have within your obliques, and the strong muscles you have within your hips, is stored in the stretch of the capsule of the shoulder and the elbow as the arm is brought into maximum external rotation. At this moment, there is this internal rotation force on the humerus. As the humerus is internally rotating and the inertia of the ball is pulling backwards, that results in a valgus torque across the elbow. This is not a functional thing to do, but this is like that's what creates the valgus torque. That's what creates UCL tears. That's the reason why generally, if you have a full thickness UCL tear, it's very difficult to return a baseball. You guys with me? This is like kind of a complicated thing to explain that we'll go through in depth later on, but it's that's the basics of it. Okay, the next thing to understand, so that's the basics of the ligaments. The next thing to talk about is the basics of stability, and this I think is like, I didn't learn this until fellowship, and I wish I'd learned it a long time before that. If you think about the way you use your elbow when your arm is like this, generally to create stability in the elbow, you have co-contraction of the flexors and the extensors, and with the elbow in extension, that co-contraction basically pulls the ulna proximally. It pulls the coronoid against the humerus. And that's what's shown in this picture. If you look at a cross section, both those muscles are pressing proximally. And this is the reason why the coronoid is so important. So if you can remember like one thing about elbow stability, it's that like the coronoid is basically the most important structure for elbow stability from an osseous perspective. And the LCL is the most important structure from a soft tissue perspective. So this is the coronoid that you can see. You can see from this cross section how that's the buttress that prevents the ulna from pulling proximally. And to create that stability, the coronoid projects farther anteriorly than the olecranon. So if you draw a line down the axis of the ulna, there is an anterior projection of 30 degrees of the tip of the coronoid as compared to the tip of the olecranon. So that anterior projection is what creates that stability. That asymmetry comes from this image. So basically you need the anterior buttress for the elbow to be stable. And I have a lecture later on where we'll talk about terrible triads and all that. But basically, if you want to understand one thing about elbow stability, it's that you need the coronoid and the radial head to provide that buttress. If you lose that anterior buttress, it doesn't matter if you like pass pins across the elbow or do whatever you want with the soft tissues, the elbow won't be stable. So yeah, you need that anterior buttress for elbow stability. And that anterior buttress can be compromised during elbow instability events. So these are these 4 stages of posterior lateral rotatory instability that were described by Driscoll. And the basic way that it works is that when people fall on their arms, they fall on their arms this way. That creates this kind of motion where the arm is going like this. The forearm is supinating. There's this varus stress across the elbow. And then basically the forearm supinates off the distal humerus through this combined compression valgus supination motion. You can see how if the LCL is going from here to here, how this like directly tears the LCL. And then you can see here how, depending upon how much force there is and the specific way in which you fall, how this could fracture the radial head and the coronoid on the way out, right? And then if you have the LCL tear, the radial head fracture, and the coronoid fracture, then you have the terrible triad. Those are the 3 elements of the terrible triad. And then once you have the full dislocation, you can see how most elbow dislocations, the ulna and the radius are posterior and proximal basically to the humerus. These pictures are just, they're like, this whole concept, it's hard for me to believe that O'Driscoll even thought this up in his head because it's such a complicated thing to come up with, but it's like, I think absolutely accurate and very useful to understand the way that generally elbow dislocates. I think you can also look at this and understand how probably most radial head fractures are like PLRI stage 0.5. And that most people have radial head, they fell and they fractured the radial head, and then there was not enough force to cause the rest of the elbow to dislocate. And radial head fractures they're by far the most common fracture we see in the elbow. And again, most of them treated non-operatively, which we'll get to. But so this basically
test LCL confidence with varus stress physical exam, but also tested elbow stress. This is both of them I described, I think, where you like test LUCL stability by putting varus stress across the elbow. You can also test for it by doing the whole like getting up in the chair maneuver where you put axial load down stress and supination.
That was on the boards this year, that question.
Yeah.
I remember. That was actually on the boards.
really.
Yeah.
I've not found that chairlift test to be perfectly reliable. I think that the reason it works is not because it puts a valgus stress as much as it because it puts this kind of like supination and axial compression. The varus stress testing is hard because if the patient is awake, they can use their extensors to overcome whatever varus stress you're placing on them.
Right.
There's a different test that I found more useful than either of them, and it's a test that I don't know if Bob made this test up, but Bob taught it to me. And the basic way that it works is with the patient relaxed, you take your thumb and put it on the radius, and then you try and supinate the forearm off the humerus. So you basically try and the meditation doesn't have to be in supination to do this. They can be a neutral rotation. You just try and take the forearm, and he describes it as a shuck. You try and shuck the humerus, you try and bring the humerus this way, bring the forearm this way, and you see if there's abnormal laxity to bring the radius posterior relative to the humerus. Did I describe that correct? Does that make sense?
Yeah, I think, it's important because the LUCL attaches from humerus to ulna, but it also is part of that complex that keeps the radial head sling intact. And when you have an incontinent one where people feel that clunk is actually the radial head.
Right.
Flexing out, it's not the lateral ulnar humeral joint gapping. And so,
Yeah,
in order
so
to
just
make that
rotational versus.
I agree I think supination is probably more, for me, supination and extension is what will bring them into that kind of position. So that's sort of where I don't do that necessarily, but I'll kind of put my finger there and, talking with them, trying to get them to relax and bring them to extension of supination. That's kind of somewhat similar.
You can do this under fluoro, and this is what a positive one looks like under fluoro. This is that test you're describing. which is sometimes called the kind of the pivot shift of the elbow, basically. And the way that this is a video of it actually working. You'll notice the patient is anesthetized for this video, so that the elbow's reduced here, dislocated there. I've found this test to be nearly useless in clinic. I mean, I think it's very useful in a patient who's anesthetized, who you've already decided you're going to do a surgery on, but I don't know. Maybe have you found this test to be useful?
Once somebody that had like a real chronic issue, but the same thing. Yeah, every one of these cases I do this in the OR, and you can do it.
Yeah.
There's just so much of that lateral musculature.
The last thing to say, and this is like, we'll, in the next, later on when I have to give a lecture on complex elbow instability, we get into this, but I think that as you go distal, one of the things, the issue with the elbow, of course, is that it's the intersection between the forearm and the upper arm. The forearm, I think the number one thing you understand about it is that it's a pretzel. You cannot break the forearm in just one place. There are, obviously the radial head is like an exception to that, but for the most part, like that's the reason why we have things like montasia fractures in both bones and, like terrible triads. So we talked about that with montasia. So these are the kind of things you need to start with. One of the problems with the elbow is you have to start worrying about what's happening distally. I've definitely had multiple times where like I look at the elbow, I can't figure out what's going on, and then I get an X-ray of the forearm of the wrist, and I realize that like it's a longitudinal instability problem, or there's something happening with the ulna more distally that I didn't realize that's causing whatever is happening proximal with the radius. That's it. We are